So good morning, everyone, and thank you very much for coming to this DC Health Systems Board event. My name is Sarah Bennett. I'm a professor in the Department of International Health at Johns Hopkins University. I don't know how many of you have come to DC Health Systems Board's events, but they're sort of fairly informal gatherings and opportunity to exchange information and experience in terms of work that we've been doing around different health systems activities in low and middle income countries. The event sort of has a number of different institutional partners, including the universities in the DC area, some of the consulting firms, some of the think tanks around DC. And so it depends very much on who feels ready to step up to the plate and actually run an event on behalf of DC Health Systems Board. This time round, I guess the event is coming largely from a Johns Hopkins perspective, but we're really delighted to have Lara Ho from IRC join us. I'm going to give a more fulsome introduction to our speakers in a minute, but I think it's always really helpful just to go around the room and figure out who else is here so that we can connect later if we want to. So I wonder if we can just go around and if I can ask everyone just to say their names and their affiliation, that would be excellent. So I can start with
Sure. Hi everyone, good morning. My name is Lijo Paina, and I'm an assistant professor at Johns Hopkins University in the International Health.
I'm Dominique Frere. I'm actually a freelance health consultant, working currently in the Caribbean.
Teresa Norton, Knowledge Management Director at Chicago, working on a PhD project about knowledge translation, so this is of interest.
Hi, I'm Melanie Morrow, and I work for ICF on the community health team of the maternal insurance fund.
Good morning, I'm Tess Shiras. I work with Apt Associates on the Shops Plus team and on the research team there. And I graduated from the Bloomberg School with a master's a few years ago in SPI.
Hi, morning. I'm Vikas. I work on health information systems and I'm at JSI, Johnstown.
Hi, I'm Leanne Doherty. I'm also at JSI, and I work on routine immunization and monitoring evaluation research.
Hi, I'm Adriana Linana, also at JSI. I focus on immunization.
Molly Stowski, I'm on the research and evaluation team at Special Olympics International.
Adam Nocum, I'm with the also with Special Olympics International on the community health team.
I'm Emily. I'm doing a Makerere Fellowship in International Affairs, which is on how to improve response to outbreaks by engaging communities, and I'm doing several fellowships in international organizations. I'm currently with Save the Children and trying to see what kind of community engagement tools one can do in humanitarian response.
Hi, I'm Brina Tiernan. I'm at the Institute for Reproductive Health at Georgetown University. I work on their Passages project.
Chio Franco, I'm just back from Mali where I was dedicated in M&E project. I'm now a free consultant.
Hi everyone, I'm Eva Bazan. I'm also from Chicago, working in monitoring, evaluation, and research team lead, and I work mainly in maternal child health, newborn health, I should say, and HIV.
Hi, I'm Tina. I'm actually a clinician and vaccines trained. I previously I'm interested in implementation research, and I'm doing a research fellowship for general internal medicine and post-maternal studies.
Hi, I'm Julian Emerson. I work for Alive and Thrive, which is a global nutrition project at FHI.
Good morning, I'm Robert Scarpier. I work at the Global Financing Facility where I report the implementation research here today.
I'm Douglas Glandon. I'm a third-year PhD student at Johns Hopkins Bloomberg School in the Department of International Health.
Hi, I'm Lara Ho. I actually went to Hopkins as well. I did my PhD in International Health at SPI. Now I work at the International Rescue Committee. I used to run our research team, but now I'm the Deputy Director of our Health Technical Unit.
Great. I think you came in a little bit late. Do you want to just introduce yourself?
Sure. Hi, I'm Olivia Sumji. I work at Management Sciences for Health at MSH, and I work with the monitoring, evaluation, and research work.
Great. Thank you very much. Is anyone? We missed anyone? No. don't think so. So once again, thank you very much for coming to this event. As you introduced yourself, many of you talked about interest in implementation research, learning by doing, so I think we've managed to reach the right audience for this event. And as always, there seems to be as much expertise in the room as there is on the panel, with no disrespect to our panelists, who I know are experts also, but I'm clear from the titles and the work that you described that you were involved in. There's clearly rich experience here, which is great. And we would like to structure this in a way so that there's plenty of time for conversation and discussion. In addition to everyone in the room, we also have a colleague, Dr. Elizabeth Ekirapa-Kiracho, who should be online. Elizabeth, can you hear us okay? And are you
Hi, I do hear you. Hi, everyone.
Excellent, Elizabeth. We can hear you. You're kind of booming into my left ear, but I think everyone can hear you quite clearly. So obviously, the focus of this event is around different methods and approaches to learning by doing, with a particular focus on approaches to engaging stakeholders in kind of implementation research processes. And this event links a little bit to a supplement in HARPS, the Journal of Health Research, Policy and Systems, which we put out recently, which was work that built upon studies we had done under the Future Health Systems Research Consortium, which is a DFID-funded research consortium that we run. So a couple of the presentations draw directly from that supplement, and we're happy to provide you with more information about that if you're interested. What we were planning on doing was starting with a slightly longer presentation by my colleague Doug Glandon, because that's linked. He and I and Lydia and other colleagues at Hopkins were involved in a paper recently, which was a review paper called 10 Best Resources in Engaging Stakeholders in Implementation Research, which was published in Health Policy and Planning. So we thought that it might be helpful to start out by giving an overview of the kind of range of methods and approaches that are out there. And then after that, we were going to have a sort of panel discussion, or with a short rounds of more lightning type presentations, looking at particular methodologies that other colleagues have used and their experiences of using those methodologies in different settings. And I'll introduce those in more detail as we go through. So we'll pause for a break after Doug's presentation, or if you have any questions, comments that you'd like to share with others, and then hopefully after the series of the sort of 3 shorter presentations, we'll have time for a full discussion. Does that sound okay to everyone? Okay, so maybe I should kick off by introducing Doug. As Doug introduced himself, he is a PhD student currently at Johns Hopkins. He's previously had 10, 15 years of experience in the field of public health, working with APT Associates for a number of years, and also was head of he was the M&E advisor to a project in Fiji, the Health Sector Support Program. And Doug's PhD work is also sort of using some of these types of approaches. So Doug, do you want to get started? We need to change the presentation.
Oh, yeah, sorry.
Yeah.
Thank you very much. So this presentation just briefly summarizes this paper, which is the Health Policy and Planning section. It's 10 best resources. So we just tried to look through what was available that would be useful to help researchers in implementation research think about community engagement. And I won't be able to go through all of those 10 resources, but I'll just highlight a few to give a sense of some of the variety of what we found. It probably goes without saying that community engagement and implementation research is important. I guess that's what drew everyone here. It's important for research in general, but especially when we're trying to understand the context and reasons why interventions work in particular places. The stakeholders in those particular places, especially community stakeholders, often have an important contribution to the success or lack thereof of the intervention. So there's an important inherent element of engaging stakeholders to even conduct the research and figure out what might be contributing to the success or not of the intervention. What we found when looking at this is that there's quite a bit of guidance in general for stakeholder engagement, stakeholder analysis tools, stakeholder mapping, but a lot of that seemed to be oriented toward national level stakeholders or institutional stakeholders. What's the position of this stakeholder group? How can we influence the position of this particular stakeholder group? What's our stakeholder engagement strategy? Those kinds of approaches. But there was much less guidance about some of the more nuanced aspects of engaging stakeholders who come from, say, a community or local district offices, district health offices, for instance. And so we were trying to help fill that gap, or start to help fill that gap, by compiling some of the available resources on this. And as the last point notes, it's not just an intellectual exercise, there are important ethical implications for this. Implementation research that looks at how an intervention is affecting the population has choices to make about whose voice is actually taken into account when deciding what is the research question that should be addressed. How do we interpret the findings and what the implications are for the findings in terms of follow-up action. So there's a really important ethical component there. And then also simply, as I mentioned before, the validity of the findings. If you're not taking into account any of the local stakeholders in interpreting the results or shaping how you construct the research, there's a possibility that you're missing a really important reality. So for those of you who might not be familiar with the 10 Best paper, the format, as per Health Policy and Planning Journal, is a series of articles that identify and outline the 10 most useful resources from a range of sources to help facilitate a better understanding of a particular issue in global health. So that's what we were doing for this topic. And the purpose is really two parts. One is to just highlight the importance of this in general, and the second is to offer some initial resources that would be a helpful starting point, keeping in mind that this is in no way comprehensive, and the resources themselves actually leave a lot in terms of what to do next and how to implement practically as a research team. So this sort of begs the question as to what do we mean by community engagement? So first, to define community, we drew from a few resources to come up with the definition of community as a group of people who live in the same local geographical area or who have some other non-spatial element of shared social identity, such as a similar trait or group membership. And then we also included local community organizations, district health planning teams, civil society organizations. So we slightly broadened that to reflect some of the key local stakeholders in implementation research. And then to build on that, community engagement. So we define that as the meaningful, respectful, and fit-for-purpose involvement of community members in one or more aspects of an implementation research project. It doesn't necessarily have to be limited to implementation research, but that was the focus here. So for meaningful and respectful, we define that as involving a mode of engagement consistent with the top 3 rungs of Sherry Arnstein's ladder of citizen participation. Those top 3 rungs are partnership, delegated power, and citizens control. And if you're not familiar with that paper, it's written in 1969. It's been around for a long time, but it's fairly informative. I think there are 9 different rungs, and the idea is that it sort of represents a continuum of the level of engagement of stakeholders in a particular initiative. So on one end of the spectrum, this category, this lower rung, is called manipulation. And that reflects the kind of tokenistic tapping of particular people from a group who are supposed to then represent that group. So I'm going into a community, so I found a community leader. This person happens to have power and authority in here. They're the natural go-to person. So I'm going to bring them onto my committee. And then that person may reflect their own interests and perspectives in engaging with the research team. But in many cases, as Arnstein is pointing out, can end up being influenced by the research team. And so it doesn't really reflect a situation in which the community's voice and diversity of interests are actually reflected and influencing the research. So these three rungs, partnership, delegated power, and citizens control, are sort of at the top end of that ladder that Arnstein talks about. And really these reflect a certain amount of power sharing in decisions made about the research between community stakeholders and the research team. And really it's sort of a gradation. Like partnership is that there is some substantial form of power sharing in decision making. It doesn't specify as to what exactly that means, but it's substantive. And then all the way to citizens control, where the purpose of the engagement is really to transfer power and authority to the citizens or community group, community stakeholders, to actually take on overall management and decision-making authority. That may be consistent with certain types of research in which empowerment is the primary aim. And then fit for purpose is included in there to represent sort of the level of power sharing and inclusiveness to match the purpose, scope, and implications of the research project, emphasizing the inclusion of those people who are most affected. So the main reason for this is that there's not going to be one size fits all approach to community engagement, and it will require a lot of reflection in terms of what's the purpose of the research. So some implementation research may be more focused on, say, trying to improve clinician adherence to certain medical or clinical protocols in the ICU or something like that. And if that is the primary focus and you're trying to understand what makes the clinicians sort of follow or not follow those protocols, extensive engagement with residents in the local community might not be the most important thing in that context. Your stakeholders may be more of the clinicians within the facility, for instance. Sort of in contrast, if you're looking at, say, a family planning or contraception program for a village, you would want to make sure that you are not just incorporating a particular, say, group of married women, which seems obvious, but you'd also want to include unmarried women, younger women, men, people of different ages. So the fit for purpose aspect means just to encourage thoughtful reflection on which groups are most affected and to make sure that that's inclusive. And additionally, to make sure that the diversity of a community is represented, rather than that sort of lowest level of that ladder where you have one person who sort of tokenistically represents a group. The methodology for this paper involved sort of a multi-pronged approach. There was a review of peer-reviewed literature, grade literature, and we also had a crowdsourcing component of the systems thinking group of Health Systems Global called SHAPES. And we started with 59 resources that we thought would be worth reviewing. And then we went through 2 rounds of reviews. And the first round was focused mostly on the relevance of the resources for community engagement and also for implementation research. And we ended up excluding 36 resources. We ended up with 23. And then looking at those 23, we excluded another 8 because we weren't able to find any literature on their use or application in the field. And we thought that was an important thing to include with the 10 best. So that left us with 15 for our second round. And when deciding how to narrow that 15 down to 10, we looked at a variety of criteria, including the existence of a conceptual framework, the comprehensiveness of the guidance offered, the apparent ease of application, evidence of successful application in a low and middle income country for a relevant context. And then also additionally, beyond the review of individual resources, we wanted to have a balance of types of resources so that the 10 best would be sort of a nice collection. So that meant that we sort of de-emphasized certain resources when it seemed that they were duplicative of another resource. The resources that we found had different purposes in different stages of a research cycle. So this representation of an implementation research cycle is adapted from the WHO's implementation research toolkit and guidance, basically saying that you've got problem identification, design and planning, implementation, analysis and interpretation, knowledge translation, iteration and adaptation. You could have various different labels for this, and that's not really the most important point. The point is that at different stages of your research, you may have need for different kinds of community engagement, and it might look very different. And so to give an example, some of the types of ways of engaging communities at the different steps might include engaging community members early on to help identify key problems to be addressed by the implementation research project, or helping to understand the context or identify key stakeholder groups to be involved. In the design and planning, it could involve shaping the research aims, designing or refining data collection instruments. In implementation, it may be the case that community stakeholders are involved as data collectors, or they may be respondents. They may be involved in helping generate local awareness of ownership. In the analysis and interpretation phase, there may be a role for community engagement in terms of discussing the findings and the implications of the findings with community stakeholders, or adding contextual depth and nuance to the findings. And in terms of the knowledge translation aspect, creating local meaning. Right? Just publishing a piece of research in a journal doesn't do much to create local meaning in the place where the research was conducted. So there's an important engagement aspect of that if you want the research to be valuable in the place where it was done, which is the purpose of implementation research. So there's a lot to think about there. And then also iteration and adaptation. So what happens after the research has concluded? It might involve establishing ongoing monitoring and evaluation, social accountability mechanisms, or some other So to give, there are a few examples from the 10 best that I wanted to highlight, which serve different purposes. One of them is this resource, Principles of Community Engagement. And this is a US-based document produced by CDC. This is really useful because it outlines some of the key principles related to community engagement that would be worth considering. A lot of the ethical considerations, and then also provide some guidance as to what that might look like practically in the field to consider some of these principles. So principles like the importance of learning about the culture, context, history of a particular community before entering that community to do research. Thinking about the experience that community has had with outside researchers coming in and trying to get an understanding of how the research team might be viewed is one example. Another principle has to do with the importance of recognizing that there may need to be a step or an element in which you, as a research team, relinquish some authority over certain decisions about how the research proceeds. And another of the principles has to do with the idea of ongoing engagement or commitment. And that's a difficult thing to fit in with certain kinds of research contracts which are time limited. And so if there's this ethical implication of ongoing commitment, but a contractual mechanism that doesn't allow for that, it requires the research team to have some discussion about how best to reconcile those. So the idea here is to provide public health professionals, researchers, leaders, organizations with some basic guidance and thinking through some of these principles. It's particularly useful at the outset when thinking about how to design, shape, and plan for the implementation of a piece of research. The format is standards and guidelines. One example that was provided, there are quite a few, but one example was a research team that formed a community advisory committee to create a shared mission statement, and then they adapted their study design to meet the community needs. A second resource is called Systems Concepts in Action, and this book incorporates 19 different examples of types of systems thinking methods that could be informative. And this could be a direct contribution to helping understand the implementation research need, or it could be something that helps shape the research team's understanding of the community context, which in turn would have implications for how best to go about doing community engagement, which stakeholders to engage, potentially helping to better understand some of the local dynamics that could shape the planning and implementation of the research. The book has sort of a primer on systems thinking in general. It includes an explanation of each of 19 methods, and then it provides some case examples and some of the pros and cons of each and some considerations of what it would take to implement them. To give one example, a case that was included mentioned the use of causal loop diagrams and stock and flow diagrams in the evaluation of a microlending scheme in a West African nation. And part of the research was trying to understand why the popularity of this scheme, of this microlending scheme among sex workers, was sort of fluctuating dramatically over time. And so they incorporated this causal loop diagram format and also the stock and flow diagram format as a way of answering that. And it was a process, a participatory process of engaging sex workers and other community stakeholders in contributing to the development of those diagrams. A third example is the engagement toolkit, a little bit different. This one has 68 different tools or techniques that are really about how do you plan for and structure an interaction with various different stakeholders or community groups. And each of these 68 tools has a breakdown of what is it, in what situations might this be useful, what might it cost, what are the resource implications, what are the steps involved, and it has some, the usual suspects in terms of strategies for engagement, like focus groups and questionnaires and public meetings, stakeholder workshops, but it also has more interesting and innovative engagement strategies, including things like electronic democracy as a way for people to provide input as through electronic means, whether by mobile phone or something else, design charrettes, and a few others, photo voice. So it's worth sort of thinking through. It's the prices are based in the Australian context, though, so that part won't be relevant for many other places. And the example here was the use of a prioritization matrix to engage users coming out of a health clinic to identify some of the problems that they were experiencing or issues they were experiencing, and then also sort of vote on the frequency and importance of those issues. So going forward, just to summarize some of the things that we found in putting together the paper, there was an ongoing need for identifying and navigating key ethical and strategic and pragmatic considerations related to community engagement in implementation research and beyond. Gauging the appropriate level and form of power sharing and inclusiveness, including who to engage and at what time. Determining whether, how, and when to apply specific approaches. A need for a better understanding of the resource, time, and competency requirements for these various types of approaches. And a need for documentation of challenges, barriers, success factors, and contextual considerations. And all this sort of points to the need for broader and more comprehensive empirical documentation of these things, because many of these are implemented in practice, but don't necessarily get documented to the point where they're widely available and that can be shared. And there may be value for having a consolidated, coherent, and curated open access resource to compile this kind of information. This is the paper, and there's a link to it in case we're going to be circulating these slides. Thank you.
Thank you very much, Doug. So we can take a pause for a minute and just see if anyone has any questions or comments for Doug. That was obviously a sort of very broad overview of some of the sort of issues in the field, but also some of the key resources that we found when we were searching. Yes, Hannah?
Sorry, I got a question. I come kind of from a scientific background. I did a math degree and some scientific research, and I'm always interested in what is the evidence we have, what is the effect of community engagement. Did you have a look into that while you were doing research about the community engagement? So if we do successful community engagement, what is the actual result of it? What does it do in terms of health impact, or what kind of indicators you find there?
I think that's also quite lacking. We're not even at the point where community engagement is well defined. And so if it's not even defined, and a lot of research protocols and studies are basically saying, well, we engaged people. But that's not a substantial part of a protocol. It's not described in methodology. There's no substantial portion of a methods section to say what we did and why and how it contributes to the validity of the findings, for instance, or what the implications are for the subsequent actions taken after research. So much of that is missing that I haven't seen any articles that would describe that. But in the HIV/AIDS literature, there may be some, because this type of community engagement, that body of work has been going on for longer. I'm not that familiar with it, but it could be there.
And do you know of anyone doing some sort of control group, comparing communities where you would do community engagement and to communities where you would not? I've seen something like that with dengue control measures, but other than that, I did not find a lot.
I'm also not aware of that.
Oh.
I think it's also important to consider that there's the element of community engagement for the outcomes of the success of the research, the eventual outcomes, but there's also an important ethical component.
Of course.
And so if it's really important to make sure that community stakeholders who are affected by this intervention or the research are engaged and voices heard, then it kind of creates questions as to whether it's appropriate to have a control group where you're going to go into a community and not engage people.
Have you seen the Svensson and Borkman paper that everyone cites? So it's a community scorecard where they actually did an RCT, and it was put out everywhere. I mean, I believe 3IE has been trying to do a reanalysis or replication. Don't remember what the results. The big paper that everyone cites, at least in the sort of governance communities, is the Svensson and Borkman paper about community scorecards in Uganda, where they actually did an RCT and showed very strong results. We did a study, an RCT in DRC that was on community-driven reconstruction that used community scorecards, which did not show the same kind of results. And there's a lot of discussion about the methodologies and sort of how you do that. But I think that's the one sort of big thing that people cite, the big study where they actually have done RCTs around community engagement.
I think there's also a difference between community engagement and research and community
Yeah.
engagement in programming. And I think on the research side, there's very little.
Yeah.
You're right about that Uganda paper, but there's also an inequality. No, it's a mixture of accountability interventions in Uganda,
Yeah.
and then it shows sort of massive impacts upon child mortality. But there's been a lot of questioning as to whether it was accurate. I believe that USAID is actually funding some similar RCTs looking at social accountability interventions. Yes.
Well, thank you for the presentation. I'm excited to read the paper now. I like the schematic showing the parts of the IR cycle. I was just curious if the resources that you found in these 10 best, did they focus on certain parts of that cycle, or did you find that, you know, maybe knowledge translation or some of the other parts of the cycle maybe people were lacking in resources? Just curious if there was an imbalance there.
Yeah, that's a really good question. Something that we thought about also. Each of the resources, I would say, have certain parts of the cycle that they may be more well aligned to, but you could make a case for using a lot of them in multiple different parts. In the first draft of the paper, we actually had thought to link them to different parts of the cycle, and then decided that would be too sort of deterministic and prescriptive and didn't really make sense, so we removed it. But yeah, I do think that it's sort of, there are sort of natural affinities between resources and parts of the cycle. I think that the majority of the resources are going to be arguably very useful at the planning stage. Some of them are going to be useful later on as well, but I think the bulk of them were sort of more front-loaded in terms of the cycle.
So I think maybe we'll move on and to the shorter presentations that we were planning. We were calling them lightning, but I think we'd agreed about 10 minutes each, so they're not exactly really lightning presentations. And the first one is going to be by my colleague Elizabeth Ekirapa-Kiracho. Elizabeth is a medical doctor with a PhD in health systems research from Trinity College, Dublin. She's currently a senior lecturer in the Health Policy Planning and Management Department at Makerere University, and she's also the team lead for future health systems work in Uganda. Elizabeth, can you hear us okay, and are you ready to kick off? We have your slides here. Oh no.
Thank you, Sarah.
Oh, good. Okay, Elizabeth, are you set?
Okay. Thank you.
We can hear you okay, Elizabeth. Please go ahead. You want me to introduce your title?
Can you share the slides? I'm not sure seeing the slide.
Okay. Yes. I'm on the first slide, and I'm also happy to move the slides. But you can, if you want to get started.
Should I start?
Do you have, if you have them printed out, I'm not sure that we're going to be able to facilitate it so you can see, unless you just turn the camera on.
Okay, so I'll just start. I hope you'll be able to follow with the slides that you have. So I'm happy to be able to share with you. I attended a meeting once in Washington, this particular meeting, and so I'm kind of imagining that I'm seated over there with you. So this presentation, I'm going to focus on giving you a brief background to where we implemented this PIPA approach. Then I'll look at the application of PIPA, and then I'll look at the experiences and the lessons that we learned using PIPA, and also look at some implications for the application of PIPA in systems thinking and complexity. So this particular project where PIPA was used was done in 3 districts in eastern Uganda, and these were districts that had poor maternal and newborn outcomes and suboptimal utilization of maternal and child health services. The main aim of the project was to improve maternal and newborn care practices and also to improve access to maternal and newborn healthcare services. The project had 2 main components. The first component was about community empowerment, in which village health teams visited homes to educate them about maternal and newborn health and to encourage them to take up different aspects of the project. We also encourage the households to prepare themselves financially by serving through local financial networks that are locally referred to as saving groups. We also improved access to transport by working with local transport providers. In addition, we implemented a number of health system strengthening initiatives that you can see on your screen. I'm hoping that you're able to see them over there.
You can.
Moving on to PIPA. Great. Moving on to PIPA. Participatory Impact Pathway Analysis is a planning, monitoring, and evaluation tool that has been designed to help implementers make explicit their theories of change, and it has also been designed to help them understand their impact pathway. We chose to use PIPA because we wanted to understand stakeholder perspectives about different actors who could influence maternal and newborn health, and we also wanted to know how these actors could be engaged. In addition, we wanted to understand what the local stakeholders considered a success in this particular maternal and newborn health project, and we also wanted to assess the implementation of the project from their perspective. PIPA is usually implemented through workshops, and it involves 5 distinct steps. The 5 steps, the first step involves the construction of problem trees, in which the stakeholders identify and understand the causes of their problems and suggest solutions, possible solutions to these problems. This is followed by a visioning exercise in which they share what they think success would look like if the project that they are involved in was to be successful. Then they develop some network maps, and in this process of developing the maps, they identify key actors who are involved in the particular project that is being discussed. They identify the relationships that they have with these actors and the level of influence that these actors have, and the extent to which these actors can be able to influence particular actions that can help the project achieve its intended objectives. So they also suggest strategies and actions that these actors can take. So all this information is finally brought together and used to develop an outcome and an impact model that explains how the impact that the project desires to achieve can be obtained through working with different actors playing particular roles. In this particular project, we did 2 PIPA sessions. We got to know about the PIPA method after we had started the project. And this was a project that had used the Participatory Action Research approach. So we did the PIPA workshop midway through the project and at the end of it. And we nested it into a larger meeting that had a diverse group of stakeholders who had been invited to participate in feedback sessions about the project. So we had the PIPA session with a small group of those participants. So in the first group meeting, we had about 8 to 10 participants. In the second round of the meetings, about 5 to 7 participants. We modified the PIPA approach because by the time we started, certain things had already been done. And because this was a project that was being implemented using the Participatory Action Research, certain things had already been done. And so we did not construct the problem trees, but we recapped the problems and the solutions that we had already obtained from the stakeholders in our earlier engagement with them. But then we concentrated on visioning and developing the network maps. And we developed maps for 3 different points. Before the project started, the current situation of the project, that was midway, and then also maps for the end of the project. We had already specified our outcomes and had agreed on certain methods to collect them. So we did develop an impact and a logic model, but then we assessed the extent to which these outcomes were being implemented. So that is basically what was done in the first session that we had. And then in the second session, we developed network maps and again assessed the extent to which the project had been able to have the desired objectives. In the next slide, you're able to see some of the things that were shared during the visioning process. This is what they thought successful implementation would look like. They thought if the project succeeded, they should not hear of maternal and child deaths. Traditional birth attendants should close shops. They should see an increase in antenatal care attendance, and the rest are listed down there. So we're able to see success from their perspective. The next slide is a network map, and that shows a map that was drawn at the end of the project. So you can see that it has 3 circles. So the actors who are in the innermost circle are the actors who they felt were closest to issues related to maternal and newborn health. And the red color there shows those who they felt were of the highest importance, and then green, medium importance, and the blue low importance. And the stars demonstrate the amount of influence that the actors had. In this particular slide, the 7 groups and the transporters who at first were in the outermost circle had now shifted to the inner circle because of the involvement that they were having in the project, and because of the fact that they were now engaging directly with others and helping them to achieve their maternal and newborn health objectives. In the next slides, I'm going to share some experiences and lessons. One of the things we learned is that pre-testing of the application of the tool is beneficial to ensure that all the facilitators have a similar understanding. When we did the training, we thought that we had all understood the same thing. But when we went out to do the first round, we found that some people had understood certain things differently. Secondly, we found that the way different stakeholders are able to come together in PIPA, the way they're able to identify their problems and challenges, and to identify actors who can make changes, and to identify different actions, brings them together and increases their ability to collaborate and work together to achieve a particular outcome. It also allows the implementers to plan things that are contextually relevant, because the stakeholders are able to bring that out, or in case the project has started already, you're able to check the existing plans. The participants whom we invited were people who were interested and involved in the issues that were happening, and so it's important that when you select participants, you select those who are interested, aware of the issues being discussed, and also involved. The diversity that the participants come with is particularly important because it allows you to capture different experiences from the stakeholders. As I mentioned, we piggybacked our meeting to another meeting, and that can help you cut down on costs when you want to implement this method without spending too much time to financial resources. However, you may find that you may lose the diversity in terms of participants if the selection was not done very carefully. One of the other things that I particularly appreciate about PIPA is the fact that it allows you to evaluate from the eyes of the community, because you're able to see what they consider as success. It also allows the team to re-evaluate how the program is performing. So in the beginning, when you identify actions that different stakeholders are going to undertake, you're not certain whether they'll undertake them or not. So this kind of meeting helps you to be able to identify what is happening. It also allows you to test your theory of change to find out whether your assumptions are still holding true, whether the changes that you expected are actually happening or not. And it gives you room to modify or change your approach so that the chances of success are increased. As I draw to a close, I'll share implications of using PIPA for systems thinking and complexity. The fact that it allows participants from a multi-sectoral level to participate, promotes collaboration. It allows participants from various sectors to participate during the identification of problems, but also during problem solving. And so this allows you to address health systems problems using a systems thinking approach. And it also helps you to demonstrate or to appreciate the complexity that exists within the system and therefore the kind of interaction that you need to be able to deal with that kind of complexity. However, if these systems or approaches are to be used, there has to be buy-in for these approaches at a global level and also at a local level. Often the research calls that we see do not put out calls for some of these methods. So if these methods are to be used more, then the research calls and the researchers that are funded need to be able to include these methods. The periods of research that are funded are also often short, and if you're to benefit maximally from the method, then research that is funded for a fairly long period gives you a greater opportunity to work with the stakeholders and to actually see change begin to happen. Lastly, if this method and other similar participatory methods are to benefit and lead to changes in the health system, several things need to be in place. We need a system that is able to accommodate or able to improve its planning, that is able to identify problems and to solve problems at local and national level, and that can be able to put into place mechanisms to address the things that the stakeholders may feel are not being done the way that they should be done. But this also requires that we have a culture that encourages innovation, and a culture that encourages thinking outside the box, so that the suggestions that are made can be put into practice. And this is also going to require that there are leaders who are able to garner support from the community, to bring the community or the district together, or to lead even at national level different initiatives that may be started through such processes and that can eventually be able to lead to certain changes that will improve outcome to health services. So those are some of the things that we thought need to be in place for us to achieve maximum benefit. I'd like to close by appreciating DFID that funded this work, the Future Health Systems Consortium partners, the School of Public Health, and the district leaders who participated in this work, as well as the community. Thank you.
Thank you very much indeed, Elizabeth. So Elizabeth, our plan was to go straight on to the next presentation, but I know it's getting late in Kampala. Are you able to stay with us for a little bit longer?
Yes, I can stay a little bit longer.
Okay, excellent. So if you don't mind, we'll move straight on and get these 3 presentations made so that you can see the variety of different sort of approaches and methods. So our next presenter is Dr. Lygia Piner. Lygia is an assistant professor in the health systems program at Johns Hopkins. She previously worked for USAID through the Global Health Fellows program, and then went on to do her PhD, actually looking at health workforce issues in Uganda. Lygia's work focuses really on the application of systems thinking tools, and she was really the driving force behind the supplement that we described earlier. And so she has experience working with a variety of different types of approaches and methods for engaging stakeholders. But today she's going to talk about theories of change and our experience with using those.
Great. Thank you, Sarah. And thanks, everyone. So, as Sarah mentioned, this sort of captures one of the tools that we looked at in the supplement. But as you see here, I'm here speaking on behalf of a larger group. And actually, I feel like I haven't done the hard work because I was brought in sort of after or as the teams were revising their theories of change. So I think a lot of the hard work was actually done by Sarah and Elizabeth, who have been involved in the process from the beginning. And hopefully this paper tries to summarize excuse me, the experience and the process through which the theories of change were developed and revised in 3 of our project countries in Bangladesh, India, and Uganda. So in 10 minutes, I won't have time to go into very much detail about each of these countries, but hopefully give you an overview of the process and the key lessons. So I guess the advantage of working with theories of change is that most people are familiar with them. Nevertheless, I think that it might be something that is actually evolving over time, in the sense of, to the extent that it promotes critical thinking and is a tool that is used more iteratively, and that has the potential to involve stakeholders outside of the research teams. So here are a couple of the definitions that I guess we focused on through our review. As most of you are familiar, the theory of change involves a diagram. So it has a visual representation as well as a narrative that goes in greater depth about assumptions, relationships, and how outcomes are achieved. And the teams used in their initial workshop to develop the theories of change a resource that is focused on developing purposeful program theory. And what was interesting about that is that it really emphasized on understanding the context, understanding what your assumptions are about an outcome chain that is developed, and then building on that this theory of action. Well, how would you intervene? So I feel like the theories of change that the projects develop are a mix of that and involve their interventions as part of the greater context and pathways of change. The teams actually started developing these in the beginning of the second phase of the Future Health Systems project, so around 2011, 2012. 3 of the teams were encouraged to revise their theories of change actually at the recommendation of the project's consortium's advisory group. Because the implementation was evolving rapidly and there were a lot of lessons learned, so this was one opportunity to encapsulate some of those lessons learned. Throughout the last few years of the project, there was a series of reflection meetings, reviews, and synthesis that also tried to understand how the theory of change is actually being used, not just how the projects are changing. So I put up here the cycle that Doug initially presented. And I guess I don't think it necessarily does justice to everything that was done, or it's not meant to assume that there are only certain parts that the teams use them for. I think that probably some of the problem identification was done sort of in the proposal before the actual country theories of change were developed. There was a consortium theory of change that addressed some of that, but I don't think the timing always fits that because of the funding process, it's not that people can come together before they put a proposal to the extent that they might after the project gets built. In the case of this project, there was a lot of use in design planning, In the implementation, I sort of drew a line here because if we assume that this cycle applies to the whole project, there is actually a lot of movement as teams are implementing, they're learning and iterating, what Elizabeth described in her presentation using the PIPA, that actually emerged as one of the things that could be applied in light of how they got to know the stakeholders better. I made this linkage here, but I'll touch upon how it was the theories of change played a role in knowledge translation and the analysis interpretation as well. But this is a bit of the process, and as you can tell, it's a process that went over a few years. And that's perhaps what is unique about this opportunity, is that oftentimes theories of change are developed and perhaps are sort of put to the side. But this was an opportunity to see, well, is there any value added to actually revisiting and to using it as a tool to sort of synthesize knowledge. So I guess due to limited time, I'll just quickly flash you a bit of what the three teams were working on. So in Bangladesh, our ICDDRB partners were working on strengthening linkages between informal care providers in the private sector and the formal health system with this idea to improve quality of care. And those are the main intervention components. In terms of how they apply the work in practice, initial theories of change were developed sort of in a cross-consortium workshop, but then there was follow-up work done using mostly the FHS team, but also some our policy influence and research uptake coordinator was engaged in this, and TRCL was one of the firms that the team was working with. So there was some engagement of other stakeholders in the initial development of the theory of change. But you'll see that even at that point, it was an iterative process. When it was revised, it mostly involved the project team, but the project team did interviews with different stakeholders, and they were able to bring in some of that information into the revision. I won't go into this in detail, and this doesn't fully tell the story, but just to give you a sense of how the diagram changes, the narrative changes as well. And you can see that some relationships may be better defined. There might be new emphases and new relationships that come out. Our team in India worked in the Sundarbans area, which is a fragile context due to extreme weather events. They were doing both operational research, and they were trying to really build knowledge transfer through a knowledge platform that coordinated different service providers. And initially, the theory of change development was sort of similar. The revision happened through a one-day workshop where they were able to bring in knowledge from these stakeholders interviews that they've been doing through other project activities. And as you see, in all of our processes, we involve the policy and influence research unit update coordinator. And you get a sense of how they changed here. I mean, by learning more about the context through the revision, the team was able to emphasize issues that were bridging outside of the health sector, and that were able to better take into account context in the Sundarbans, both in terms of the service providers that they were working with and also the needs of the different stakeholders, and really having a broader, whereas I think that the team really focused perhaps narrowly on one health area, they were able to broaden that and look at child health more broadly as they learned from implementation. In Uganda, Elizabeth already mentioned a bit about the project, so I won't go into detail, but to emphasize that the team did use a participatory action research approach, so they had a lot more opportunities to engage with stakeholders through that approach. So the team actually developed the theory of change through a longer process, and in the design phase they started consultations, and then they implemented through the actual local stakeholders there. And as you saw, so the PIPA exercise was, I guess, on a timeline done after the theory of change was revised, so it was an opportunity to look again at the assumptions in the revised theory of change. And I'm highlighting that just because because in practice, I think, and that might be all of your experience as well, in practice there are multiple tools and multiple ways of engaging with stakeholders throughout the research cycle, and this is an example of such an engagement. The participatory action research approach was something that emerged, and so the revision of the theory of change is what highlights it further. And I guess in the last couple of minutes, I gave you a very quick overview of what the teams did, how they did it, and I guess I'll leave you with some reflections on what were some of the uses and potential lessons learned. These are detailed further in the paper. I won't go into them in very great detail, but just to say that we looked at these 4 areas. In terms of strategic planning, there was an opportunity, especially in the beginning of the project, for teams to learn from one another. And although this wider cross-consortium theory of change wasn't as relevant to the local context as the individual ones that the countries prepared, this was an opportunity for, well, in the beginning, teams came together and learned from one another, and as the process revised, they were able to capture lessons through
from the 3 countries.
From the 3 countries. Well, in the beginning, all of the 5 countries developed this theory of change, but only these 3 revised them because of a variety of reasons and control over intervention and whatnot.
So they came together. The countries met across country.
In the beginning, the countries met together, and they were able to share each other's theories of change and sort of consult with one another before going back and doing the more extensive stakeholder interviews. A lot of the use was around communication. One of these being within the teams. The second sort of being with other stakeholders, not necessarily of sharing the diagram, but really taking the assumptions and what goes into the theory of change and bringing that out to stakeholders. So a lot of the engagement happened in terms of well, sharing the insights with the consortium as a whole and bringing in capacity building as needed. Externally, I mentioned some of the inputs to the theory of change process, but I think some of the learnings that the teams gained through this revision perhaps also influenced how they communicated with other stakeholders. And because it was tightly linked to our Peru team, this also facilitated some of the products that we used, and then that fed into knowledge translation. A lot of the learning was facilitated through theory of change, and I guess in the this sort of also promoted the iteration and worked through the iteration part of the cycle. We also examined whether the theory of change focused on accountability and helped to draw accountability lines. I think that the teams were accountable through donors, but I think that the theory of change wasn't necessarily the main tool used for that. But there wasn't necessarily evidence of the theory of change, like as I mentioned before, taken as a tool and taken to other stakeholders. But it was more the lessons and the process through which the countries engaged. So I'll just leave you with a couple of notes on the engagement. It was this periodic reflection, I think, that helped both to engage the stakeholders that were part of the research and then external stakeholders. And that's what I would say came out as one of the main value added of using the theory of change in addition to other engagement processes. It was, in this case, a potential tool that facilitated incorporation of learning and incorporating feedback from stakeholders, and it prepared the teams to understand how to engage with stakeholders moving forward, especially in the last part of the project. I guess finally, it's one of those things where as you saw, the tool itself and the theory of change might not have much a life beyond the project, but during the project, through the process that it helped facilitate, it guided this capturing learning, and it guided bringing in stakeholders at particular points in time. So I'll leave you with that, but in the question and answer session, Elizabeth and Sarah are also here as part of being actually involved into the actual development process. So
thank you very much. Thank you. So we have one more presentation. Thank you. We have one more presentation. We're going to keep going with that one, and then we'll open it up to broader discussion. So I'm delighted to introduce Lara Ho, who, as you said when you introduced yourself earlier, is the Deputy Director of the Health Committee at the International Rescue Committee. She received her PhD in International Health from the Johns Hopkins Bloomberg School, and has been working with IRC largely since, working based in Tanzania with Burundian refugees, also as coordinator for IRC in Cote d'Ivoire, and I think the work you're going to talk about today is based in Liberia.
Yeah.
Over to you, Lara.
Great, thank you. So just a really brief background on IRC, which sets the context for why we did this work. Our mission is to help people whose lives and livelihoods are shattered by conflict and disaster to survive, recover, and gain control of their future. So this means we work largely with people who are displaced, the host communities that receive people who are displaced, and people who may be affected by conflict who can't flee. So it's largely humanitarian work. We are an implementing agency, but we have an organizational commitment to generating evidence and using evidence. So we do a lot of research, sometimes independently, sometimes with academic partners, large impact evaluations. One of the things we find, though, is that doing RCTs are great for influencing global policy and getting WHO to change things. But we struggle even to get our field staff sometimes to use those results, and getting the research uptake within the organization is still a challenge. So I've pushed a lot to do more implementation research, operational research. This project is very dear to my heart because during the Ebola outbreak, I actually went to Sierra Leone for a couple months to help the organization set up isolation units, and on the side I decided for some reason to do some research on infection prevention and control, which I would not recommend trying to do research in the middle of an emergency unless you were very well prepared to do that and not focus on the program pieces. One of the things we learned as a side effect of the research in Sierra Leone was the psychosocial impacts of the Ebola outbreak on healthcare workers and the stigmatization. It wasn't the primary aim of that research, but it came out of that. And so towards the end of the Ebola outbreak, I went back to Liberia to do some work with our team there. I have to give some credit to Renee Lowenson, who wrote the Participatory Action Methods Reader for the Alliance for Health Systems Policy and Research. It's a great resource. I had talked to her at, I think, at the Health Systems Global Conference, and when the Liberia team came to me and said, we have this problem with maternal health in our programs, and we want to do something to figure out what's going on. I'm losing my battery. Okay, well, I have the slides here. I talked to the team and chose this particular method. This picture is just a card from when we were training the community researchers, and one of the pregnant women wrote this, which really struck me about how important this project was to her and doing something about what was going on in her community. So just a couple words about participatory action research. I think we've covered a little bit. I think in Douglas's presentation, he really talked about the ethics of participation and the ladder of participation. And one of the things that PAR is really intended to do is shift power, right, from the researchers to the communities who are being affected by particular problems. And the idea is that the researchers are community members. It's not an external thing. We're empowering people in the community to use their own knowledge to take action to address whatever issues they've identified as a priority. So this is actually a photo from outside the community center in New Crewtown in Monrovia, where we did the training of our community researchers. And I just liked it because this sign you can see is about paying taxes. And so IRC's worked in Liberia since the civil conflict, which lasted for many years. It was a very bloody conflict. And that really, it destroyed the health system. It created a lot of issues of trust, and there's a lot of governance issues in the country. And that was sort of the backdrop which Ebola happened. And as many of you may have read about, particularly in Liberia, in West Point and a lot of the urban areas that were highly affected by Ebola, there was a lot of mistrust of the government, but not only of the government, of healthcare workers, and a lot of issues between community members and different stakeholders. So this is the sort of context that we were going into. We have been working throughout the old Ebola outbreak. So in particular, we were working in New Town, which is a neighborhood within Monrovia. The main public hospital in Monrovia, Redemption, was affected by the Ebola outbreak. There were many Ebola patients who died within Redemption during the crisis. They ended up closing the inpatient facilities there. The outpatient services were still running nominally. And IRC went in, I think, around December 2014. After the hospital had been completely decontaminated, we helped reopen the inpatient services. And one of the things we found was that although people were coming for antenatal care, the outpatient services were continuing to run, in part because of the infection control measures where we said you can't have 3 women laboring in one bed, which used to happen. There was a huge drop in facility-based births during the crisis, and even after we reopened the facility, there was not an increase. We expected that once everything was disinfected, providers were working again, that would recover, and it really didn't. There was just a drop, and it maintained a very low level of facility-based births. And we knew that during the crisis, a lot of traditional, so what they call traditional trained midwives, so this is before the move towards facility-based birth, they trained TBAs to do home delivery. So there's this cadre in Liberia of trained traditional midwives and TBAs who they were doing most of the deliveries at home during the crisis. And that even after the crisis had subsided, that was still happening. And so we wanted to figure out, what's going on, what do we do about this? This is, delivering at home is really not the ideal. The government policy is that all births should happen in a facility with a skilled provider. So our objectives really, as I mentioned, were to figure out what was going on. We knew there were weaknesses even before Ebola within the health system, but we wanted to identify some actions that we could do to address these gaps and strengthen positive practice, and really wanted to establish a collaborative coordination of actions taken. Just because of this community, we've been working there throughout the crisis, and we knew there was a lot of issues of mistrust. So in the process, in part, there are different stakeholder groups, and so you do a series of meetings with each group, and then you bring them all together to do sort of an interface meeting where they actually do some planning. So we had 3 main groups. One was the actual pregnant women who were most affected by this issue. Then we had a community group, which included women community leaders, trained traditional midwives, as I mentioned, and untrained TBAs. And then we also had some male councilmen and some of the elected local administrators and traditional leaders. And then we also had the staff from Redemption Hospital, those who worked in the maternity and the antenatal care services. And so these were the 3 groups that we actually trained community researchers from each of these groups to help facilitate the sessions. So this is just the cycle of PAR, and it's going back to Douglas's cycle that he looked at of the research cycle. The community members are involved in all stages, right? So everything from systematizing their knowledge to collecting and analyzing it, evaluating, taking action, and it's really a spiral. It's not a linear process. So the idea with PAR is that you keep going. So we were there to support the first cycle, but we expected that there would be continuing cycles even after our support ended. I'm not going to go into the details and methods. We just published a paper in Global Public Health, so you can go read all the results there if you want, and I'm happy to share the report, which I think is also online. But just to give you a highlight of some of the activities that actually happen in PAR. So we do, sorry, this is a wide slide, but this is about social mapping. So looking at important places in the community and accessibility of these services. We also did Venn diagrams, and this is similar to I think the first presentation that Elizabeth did, where we looked at the importance and the accessibility of maternal health services. So the larger circles have to do with, I think, key people, and then the distance has to do with how accessible services are. So looking at a pregnant woman and the different things that she would access during her pregnancy. We also looked at the impact of Ebola on maternal health. So we did some exercises where they listed the major impacts, and then those are kidney beans, and they use the person's vote on which are the most important impacts. We also did some pairwise ranking to look at what were the main barriers. So after all these meetings happen, so they happen within each of the 3 groups, and these are facilitated by the people that were trained at the beginning, who are members of these groups. So there's 2 pregnant women, there's 2 community members, there was 2 people from the health facility. They come together, they share all the results, they look at the areas of intersection where there's consensus, and then together they think about what are the actions we want to take and what's the plan we want to develop to address what we've identified as the issues. So some of the things that came out of this was improving the manner of approach between patients and staff, more education and communication between the hospital and the community, and improving the collaboration between the hospital and the TBAs. And so each of the groups actually chose specific actions that they wanted to lead in this process. I'm gonna, the next couple slides, get a little more, So again, I'm not gonna go in depth into the results because you can read about these in the paper, but a couple things that struck me were that, and why this method was important, is that, one participant said that nurses are afraid of patients and patients are afraid of nurses. So this meant that during the crisis, a lot of community members really felt that there was a huge barrier, that the hospital was this fortress, and a lot of people didn't want to go to the hospital because they knew a lot of people had died in the hospital of Ebola. But even then, they just didn't know what was going on in the hospital, right? And I don't think a lot of healthcare workers were aware of that. At the same time, healthcare workers felt incredibly stigmatized. There's stories of people who their relatives wouldn't come visit them because they knew they were working in healthcare centers, regardless of whether or not they took care of Ebola patients. But there was a huge stigmatization, and the healthcare workers really felt very isolated. And so bringing them all together in the same room, they really talked about their experiences, and they understood what was important to each other and what everyone had gone through during Ebola. So talking good. So this is another thing that came up. So for healthcare workers, when you ask them about, what is quality healthcare, right? They talk about, oh, do I have drugs? Do I have the right equipment? Do we have the training to deliver the services? For patients, particularly in this community, quality is more about how they're treated when they arrive at the hospital. And this is something that I think a lot of the nurses were not aware of. They were very focused on, do we have the materials and equipment we need? But for the patients, really, it's about, are they spoken to nicely? Do they get respect from the healthcare providers? To them, that's a measure of quality, which I don't think a lot of the nurses realize. And so, when they say, this is Liberian English, when they say talking good, this means that the pregnant woman, they want to be spoken to nicely. They want to be greeted. They want to be welcomed in the health facility. And so that was something that came out of this that I think was some shared learning for both groups. And then another thing, so going back to this idea of shifting power, so at the beginning, I was in the training that we did for the researchers, and the pregnant women, they tend to be quite young. There was, during Ebola, there was a lot of unplanned pregnancies post-Ebola. These were very young women, and they were pretty quiet in the beginning. And through the process, we really saw them as leading their groups, becoming far more vocal. At the end, they decided that they wanted to set up a drama group to educate women in the community. They were getting technical support from the healthcare providers, but they were the ones running this drama group to educate people about what to expect when you go to the hospital, how do you prepare, what do you bring. And this is something that one of the nurse managers at the hospital said afterwards, and really reflects sort of their acknowledgement of the role of pregnant women, that we have to remember why we're doing this. This is about the pregnant women. They're the ones who are important. And that was a significant shift, I think, in how people perceived what was largely, low-income community and women who often perhaps were not having the space to express their needs. And so that was quite significant. And then this photo is just an exercise we did at the end of the training, where there's different colored pieces of paper representing the different groups. And if you had to walk across the room, if you can only step on one color of paper, you can't make it across there without touching the floor. But if you are able to step on any of the colors, you can make it across. And it's to highlight that if they all work together, we can achieve the end goal. But individually, it's very difficult to get to where you want to be at the end. And so another thing that one of the supervisors within the hospital maternity ward said, this is what she was saying to the TBAs. She was inviting them into the hospital, which is not something that used to happen, right? A lot of times TBAs would just, meet their women in the community, they would have the births, and they were reluctant to send them to the hospital because, they traditionally didn't accompany them, and many women didn't want to go to the hospital without their TBA who had done their antenatal care. So this was a big changed too, that the hospital staff invited the TVs to come in and participate during labor while the women were there and accompany them with the skilled staff. So that was a big change. So I mean, a couple things. As I mentioned, I mean, my background is in mixed methods, and you know, doing traditional qualitative research, you do all these interviews, which can take several weeks. You have to transcribe, you have to translate, you have to analyze. I mean, this process can take months, right, to get the results back and then make recommendations about what to do. In a humanitarian crisis, our programming cycles are 6 months, 12-month grants. I mean, you can't do that. By the time you have the results from the research, it's not very useful, right? Your project is over. So doing PAR meant that we had real-time visualization and presentation of the data and the results with the community members. They were seeing what was happening. They were the ones generating the knowledge, and they were able to use this information immediately to adjust our programming. And you know, we were still supporting the hospital at this time, and we could make changes. So that was a really important piece of why this method was important, particularly in a humanitarian context where you have very tight time schedules and you don't have the luxury of a 5-year development project to be able to make changes. And then again, it's really about the fact that they're participant researchers. So the key stakeholders were there exchanging data directly with each other. We saw at the end of the first meeting, I remember, the TVAs were exchanging phone numbers with the nurses and saying, okay, you know, I'm going to call you and to see if there's a bed available in the hospital so that, you know, I know that I can bring my client to the hospital right away. And it was really, there was striking sort of realizations from different groups that they didn't, even though they all worked in the same place and they were all in this community, that a lot of the healthcare workers don't live in the community, they come from other areas. So really mutual understanding about what's going on and what the issues are, and being able to then do something about it, you know, in their day-to-day actions. And then again, the stakeholders defining action and recommendations. You know, we could have come in and told them you should do this and you should do that, but the uptake probably would not have been very large. And so we did have IRC staff who were facilitators in the process, but I mean the staff who were facilitators, one of them was someone we hired from the community during the Ebola crisis, who's a community organizer. And you know, I saw him, so I think we actually presented this at Health Systems Global in Vancouver, and we were able to bring him from Sierra Leone. And he told me that, you know, after the first cycle, IRC had finished the project in the community, but he was part of the steering committee of the group, and they were still meeting on a monthly basis. They were meeting with the hospital administrators and the community members, which is something that had really not happened before. And so they continued moving on through this process, and that was, I think, quite significant that they still were very motivated to work together. That's about it.
Great, thank you very much. So thank you to all three of our presenters. We are now open for comments, questions, other contributions. Please, yes.
This is to the first speaker. I agree that participatory is a very nice approach and everybody's involved. But I was wondering, like for instance, under the section of visioning, we had like achievement of the outcomes set where like no deaths in maternal and newborn side. Would the mentors not like to sort of get involved to set more realistic goals, because such goals are impossible to achieve in a research project and totally impossible in programmatic implementation. So, and it might be disheartening when they find they cannot really achieve it. So would that be something to consider? We don't want to force our ideas on anybody, but maybe some inputs and discussion may be required.
Excellent point. I'm not sure if you heard that, Elizabeth. Would you like me to repeat it for you? Was that clear? And I'm going to
yes,
and if you don't mind, Elizabeth, I'm going to suggest we take several questions and then we can come back to the panel, just so that we can hear from everyone else as well. Rena.
So this is great. I'm a little unclear, so I'd appreciate if everyone could clarify the distinction between using this kind of participatory research to actually inform the programming. I mean, I think I understood maybe primarily from your presentation that it created solutions, but they sounded more like people said, oh, I could start doing this, rather than sort of a more systematic kind of programming kind of solution. So that's the question.
that's something that could be relevant, I think, to everyone on the panel, yeah? But
Yeah.
the extent to which we're using this to inform sort of systematic programming versus more spontaneous.
And it seems like, in a way, a quality improvement process, isn't it? Yeah.
Great, if you don't mind, we'll keep going around. Any other comments, questions? Yes.
Just to echo your point, which is, I wanted to mention that before when Doug Glandon was speaking. I mean, I love this very comprehensive approach where it's very meticulous and thoughtful. But for me, it's kind of like when you're implementing on the ground, you don't necessarily have that time period or the budget to be able to do the meticulous steps that are the good practice. So how do we take these wonderful ideas and translate them to the reality on the ground when you often don't have ample time, ample resources to use those best practices?
Thank you. I think that also echoes something that Elizabeth was saying about the kind of funding that we get for this kind of work and how that can be a constraint upon our ability to pursue these kind of approaches. Yes, I'm sorry, I don't know people's names, I'm just kind of waving at you.
I wanted to build on that, the question that what you mentioned about funding with all those constraints. I just wanted to get a sense of, in the projects that were in the research that was presented, how frequent were these, was this participatory approach implemented? Was it like a one-time thing in the middle, or was it at multiple times that you kept iterating and feeding back information back into the project?
Did you get that one, Elizabeth? Because I think that's certainly relevant to you. It's about the sort of the cycles of engagement. How frequently were you engaging communities? Was it continuous or just once off? She can probably hear you down that end too. But lady in the back row over there.
I had a question, again, related in terms of assessing the quality of the implementation of the research rather than the resulting product. So, how do you assess that what you're doing is actually, like you said, best practice or high quality?
Excellent question. That's quite a few to get on with. I wonder if we can. I'm very glad I'm not on this panel and just directing traffic, as it were. But maybe we can have some responses to those, and then I can see that there are other questions in the audience that we can go back to. Elizabeth, could you hear? How much of that could you hear, or would you like to take a first stab at some of those?
The first one, visually, is the one which I hear. You could briefly just summarize the first one.
I'm sorry, you were going a little bit fuzzy there. Were you asking us to summarize the first question?
Yes.
So I think the question was really about, the questioner had noted that in the visioning, the community members had articulated a goal which was really to completely eliminate maternal neonatal deaths, and was questioning whether this was really realistic, and then what is the role for the facilitators to help sort of set realistic targets. Did you get that?
Yes, I did. So maybe beginning with that, I think that's indeed a challenge that we face with communities, especially when areas where the literacy level is a bit low. At times you can ask for direct them in a specific direction, but then they think more broadly. And I think in a sense that tells us what they are thinking coming to context where they're coming from. So in our case, we found that most of the things that they suggested, most of the outcomes were directly related to the work that we were doing. And then maybe it's the impacts, like when they say, when we see no maternal deaths and no children dying, that's of course something that you cannot be able to achieve in the short term, but still it gives you, it shows that in the long term, we can be able to see that if this works, this is the kind of situation that we'll be able to achieve. So the role of the facilitator, I guess, would be to encourage, them to mention whatever they want to mention without shutting down those who may mention certain things that may not be applicable in the project period. The question about the cycles and how frequently the cycles are being done. In our case, we used to have quarterly review meetings. We implemented this particular project for about 2 years, and so we would have quarterly review meetings with stakeholders at various levels, that right from the community, the district, the implementation with us as a research team, and would review the information that is coming out. We did not change the intervention components themselves, but we often found that the changes related to the mode of implementation. For example, for the community dialogue, we used to have village meetings, but along the way, the feedback was that after the project can be difficult to sustain these meetings, and there was a suggestion that these meetings should be held through other smaller groups that were regularly meeting, and so eventually we changed to have these meetings within the 7 groups. In another case, it was just feedback about our implementation, in which we're using the community development officers to mobilize the groups and to tell them about saving. And then, this is their work because they're government employees, and initially we assumed that they would just do that. But through the review meetings, we began to notice that they had problems to facilitation. We needed to set for them more specific targets. So it's really the implementation of particular things that we're doing that we found that we change. I think those are the two that I got. I think there's a question about how realistically can we apply these methods. I think often, depending on your context, you may find that you have to modify the standard definition of the method. So sometimes you may find that organizing an extra meeting would cost resources that you do not have, but the option of piggybacking it to another meeting may exist. Or in some cases, it takes a very long time. Maybe these workshops, for example, for PIPA, the literature says that it takes 2 whole days, and the participants may not have all that time. So at times you find that you need to consider and see what you think is relevant for you and for the project, and pick up on those aspects. You may find some parts have already been taken care of using other methods. So it becomes unnecessary to adapt the method and modify the suit learning.
Excellent. Thank you very much indeed, Elizabeth. So there's a couple of other questions which I think we haven't got to yet, certainly with this one around the extent to which this kind of stakeholder engagement is informing sort of systematic programming versus more spontaneous actions. And also, how do we assess the quality of the research of this nature? So it's very clear how you assess quality of more sort of quantitative methods or qualitative methods, but this I think is a little bit less clear. Maybe I can come to you, Lara, particularly around the first one, and maybe start on the second, and then come to Lydia.
Sure. So in terms of systematic change, I mean, I guess I would hope that when we design a program that we have a theory of change for what we think will help us achieve the results of the program, and yes, I mean, these methods are a method of quality improvement to a certain extent. I think it also serves as the formative research to understand, okay, we came up with a theory of change when we wrote the proposal, and we need to test whether that theory of change actually holds true, and participatory action research can help identify what the bottlenecks in the pathways are and ways to address those bottlenecks. So I guess it would help us sort of design or modify the program to achieve the outcomes that we had thought of in our theory of change. That would be my hope. I don't know if that always holds true, but I don't know if that answers a little bit the question of how I would see that fitting into a program setting and designing the program.
Yeah, I just was wondering if these experiences include that, or if we're just talking about sort of the participatory process and the research part, but not as much the what do you do about it part.
Yeah, I mean, for us, we've done this also in Karamoja with one of our family planning and immunization programs, and it was very much to sort of shape how we deliver our programming. And so we're now working on a project on adolescent sexual and reproductive health that includes it, to look at how do we improve our adolescent health services and ensure that they're adolescent friendly. So I think as an implementing agent, we try to use it in that way. Regarding the quality of research, I guess from a programming perspective, the ultimate end is, do we achieve the outcomes that we said we would do in our program? And if we are meeting those targets and we do achieve those, I would hope that indicates that the research we did was useful and of good quality. I don't know if, in terms of sort of, I think the regular processes apply in terms of, it's still a systematic process, right? There is a study protocol, you have different steps, and I didn't mention this, but we actually did a survey in the community before and after to look at people's attitudes and impressions, and so there are other things that we did to evaluate whether we actually saw changes, and I guess that's the way we would look at whether this was successful.
Well, that's whether it was a successful program.
Yes, yes.
You want to add to that?
Sure. So maybe first on this idea of how do these tools inform systematic changes in programming. And actually through the reflection meetings, at least for the theory of change, we found that, so the initial theory of change was developed, most of the teams then started implementing. Through the implementation, there were barriers that were identified that were sort of challenging maybe some of the initial assumptions that the teams had. So for example, in Bangladesh, their private sector partner just wasn't a viable partner anymore, so they had to reorient their strategy. So the theory of change revision then came sort of as a reflection, like halfway through the project, it was encouraged to maybe say, well, we've changed our implementation strategy, there are new contextual factors that are relevant. We've changed how we're doing the implementation. Now let's reflect on why, and maybe like what does it look like now, and how has our sort of background understanding changed. So it's not that the theory of change led to perhaps changes afterwards, although I think in a way in Uganda where maybe the PAR sort of facilitated a more emergent approach, it sort of brought up maybe the relevance of applying PIPA, but it didn't change the nature of the intervention as much as it summarized the lessons learned in the first phase. I think that in the literature, there's this idea that yes, it could, if you do it by the book, you sort of can then do it before, and sort of reflect before you make changes to the implementation. But I think in practice, because sometimes the context changes so rapidly, at least in this case, it sort of summarized the changes and new assumptions, etc. And in relation to the quality of the research and the program and engagement, I guess I would maybe echo what Laura's saying, that it's sort of this built-in process. And I guess something that we've been trying to do in Future Health Systems, and I still feel like we're refining it over time, is adding this component of process documentation. So, for example, when we looked at the theory of change, we tried to have a guide to, sort of lead us through these reflections, so that the reflections are systematic and that teams are able to participate in in a similar way. In our, I guess in our current work, so not an example of what happened in the past, but in our current work, we're trying to see, okay, in meetings that are supposed to be participatory, can we observe how people participate and reflect on that? And can we do things more prospectively so that we don't just reflect back, but we can be more engaged in the current implementation and move forward? So that's sort of something that came from the second phase and that we're trying to apply going forward. So I think we're still refining it, but it's this idea of also trying to understand the process, and that might touch on some of the quality issues as well.
I actually think this point about the quality of this kind of research is something that might be worth thinking further about. There's obviously very clear standards now for other types of research. It would be interesting to try and put those kind of standards together for this. So there are a few other hands up. Yes, please.
So I work on a gender equality adolescent sexual reproductive health intervention in Kinshasa with 10 to 14-year-olds. And I was wondering if anyone on the panel had reflections of resources for youth or using participatory methodologies with youth.
Yeah, excellent. And it may be that Lara has was talking about youth just now. I thought I'd seen another hand earlier. Yes.
I was wondering, I guess in our proposals we have a lot of jargon and we pitch, I'm going to be doing implementation research, or I'm going to be doing participatory action research. And I'm wondering what, if anything, really is the distinction that this group of researchers draws between those different types of research, because at least in the first presentation it was focused on implementation research, but through all the community engagement mechanisms, it really sounded a lot more to me like some sort of, participatory action research or participatory-based research. So is that just a jargon distinction, or is there something more substantive there?
There's certainly a lot of terminological confusion in this space. Yes,
hi, thank you for this interesting session. It's really exciting to really look at just beyond the building blocks of typical health systems and sort of look at other areas. I was wondering sort of how has the team thought about it, or is there an opportunity of what we're hearing here is, kind of moving forward, if we can just bring somehow we can bring the research and practice together. I mean, on that end there's some here as well, but the research expertise, right? The team that can learn around it and can really inform that what works, what may work in that context. But there are many practitioners here as well, and they may be just kind of different funding and different projects. But is there an opportunity of even different projects coming together and sort of building on top of existing implementation, sort of having research? So I don't know if that is it possible? I know there are contractual sort of differences as well, but just throwing it out there to the group, if there is an opportunity, and how do we make that happen?
Okay, interesting point. Any other, so we're nearly out of time, and I will try and finish at 11, but maybe just one more question and I'll go back. Yes.
Hi, this is Teresa Norton. So going back to conducting the Theory of Change revision workshop, I am interested in documentation, a guide, or anything that would lead someone through how do you plan and conduct one of these. And then the other question was for Dr. Kiracho, and that was one of her slides mentioned culture of innovation, and I wasn't quite clear on what was the context of this. Who needs a culture of innovation in terms of what she was speaking about?
So Elizabeth, that last question was targeted very specifically at you. Did you hear it?
No.
So it's really about, one of your slides talked about the culture of innovation. If you could just clarify your thinking there about where does that culture of innovation need to be, and how does it connect to what you were talking about in terms of the use of PIPA? So another round of really excellent questions. I'm going to ask the panelists to be brief in their responses, and maybe we'll go at this, put you in the hot seat first, Lidja, because you got all the time to think last time around. So I don't know if there's any of those that you'd like to...
Yeah, sounds good. Well, I think the one that most directly was through the presentation was from Teresa about the Theory of Change revision workshop and whether there's a guide. I'm not sure that we had a very structured guide, but I'm happy to share, I guess, the approach that we used, and we had sort of not a checklist, but we developed a document that would help to capture some of the reflections from the various teams, and I'd be happy to share that. Oh, yes. Thank you.
Excellent.
So maybe I'll leave time for others to...
Okay. You're not going to tackle these difficult terminological ones for me?
Oh, on the terminology, sure. Maybe I can add a couple of my 2 cents. I think that, at least the way that I look at it, I think that, so there is confusion, as Sarah said. In my mind, the way I keep things clear is that I guess I see the implementation, research and implementation approach as sort of the overarching category, and then there's a collection of tools and approaches under which participatory action research is a way to do implementation research. And then, theory of change would be a tool that is used to facilitate that, and to the extent that is possible, also potentially bring in stakeholders. The tools that Doug mentioned are also obviously additional resources. So that's one way that I, simply, oversimplify things to make sense. But I think others might have additional insights.
So Lara, I think that someone had caught your ear, but there was a question specifically about tools for working with youth, and I think I caught you saying something about that, but also maybe you want to touch upon this point about bringing sort of research and practice worlds together.
Sure, working with youth. So we actually do a lot of research and obviously programming with youth. I don't know if there was a specific, one of the things, we've done some work in Eastern DRC around family planning with adolescents, and it was a participatory sort of approach. It wasn't really research, it was more sort of, quality improvement within the programming. But we found that worked very well. Adolescents want to be involved. They have things to say about services for them, and so this was a really good way to engage them in some of these actions. We found, healthcare providers are often very reluctant to engage, particularly on issues of sexual and reproductive health. So we have been doing that, and we have a project coming up in Nigeria and Cameroon. Just regarding the implementation research, the terminology thing, there's a good paper by David Peters that came out a few years ago that sort of talks about implementation research and then different methods that would fall under that. I think I don't remember which journal it was in, but it's on the Alliance, so it's probably on their website. In terms of research from practice coming together, I mean, that's sort of what we are trying to do. I can't say that IRC's answered it, but we have a research unit. We obviously primarily do implementation, and that's a huge piece. We have an evidence to action team that's trying to bring that together. I think there's still a lot of work to be done, but we collaborate frequently with academic partners, and I hope that through that we're bridging some of those gaps. But it's still a challenge, but it's really an important thing to us to bring that together.
So just to note, I think USAID has issued a few calls recently that explicitly try and bring together research communities and practitioners, these PAA.
Yeah, I mean, R2HC, Research for Health and Humanitarian Crises, is a mechanism funded by Wellcome Trust and TIPID that explicitly requires that an implementing agency has to work with an academic partner to access this funding, which is specifically for humanitarian contexts, but has been a useful way to bring together lots of partnerships.
So, Elizabeth, the question for you then, actually I think there's one relevant, maybe you want to talk a little bit about the photo voice and youth that you used in Uganda, and then, I can't remember the question that I just repeated, but...
Culture of innovation.
Culture of innovation, yeah.
Thank you. The reason I brought up the issue about the culture of innovation is sometimes we find that people, when they go to the field and they're used to doing things in a certain way, or we think certain problems can only be solved in a certain way. And then you go out there and the people in the community are actually suggesting something else. And I try to find that people are used to doing things the way they used to do them. But if they suggest something, you need to think, okay, try that out. For example, in terms of encouraging male involvement, one of the recent projects, we found that the health workers would take a photograph of a man who killed his wife, and people wanted to have their photographs taken. So just taking a photograph of them as a couple encourages them to come together. The other way that people have previously looked at that is that lady found that she doesn't have her partner. Those who provided services immediately, those people with their partners would receive services first, but these people are now proposing a different way of trying to encourage male involvement. So it's just the issue of being ready to allow people to think out of the box and try out different things that they think would be a possible solution to their problem, which they may not have thought about before as an implementer or even as a local
Thank you very much, Elizabeth. And I'm not sure if she caught my other comment, but one of her colleagues in Uganda worked with youth there and used photo voice as a way to engage them in identifying barriers for women in keeping antenatal care. So I can give you that publication if we're, so thank you all so much for engaging. Yes, very briefly.
Okay, very briefly. So the question about jargon related to implementation research, participatory action research. Implementation research is focused on, it's really driven by the nature of the question. Why does something work well in this place and not in another place? What are the contextual factors that affect that? Participatory action research is more about an approach to research. So it could be directly related to implementation research, but it's really about the way of implementing it. Similarly, implementation research has that as a question, but there could be multiple ways of approaching it. So you can imagine a Venn diagram in which implementation research is here, it could overlap with participatory action research, but not necessarily. But yeah, as Lara said, there's lots of documentation on that. Regarding Dominique's point, just is over there. She was asking about, well, what do you do when you don't have the time, budget, and resources to implement all of this stuff perfectly? And I think that one way to start would be just start with the principles, given the time and context that you have, and have the research team, whoever's involved, just reflect on those and see how could that potentially be implemented. And then based on something, if you feel that it could be incorporated, there are a lot of other resources that can actually draw on and help provide practical guidance about how to implement that. In terms of the quality of the implementation of the research, I think as the nature of research rigor has evolved with the incorporation of mixed methods in particular, there was that evolution to think about elements of rigor that vary depending on what you're trying to accomplish. Maybe there would be value in considering elements of rigor related to community engagement for this kind of research.
Okay, thank you. So thank you all so much for coming and for participating so actively. It's great to see so much interest in this field. And we'll continue to keep you on the mailing list if that's okay about these health systems board events. Thank you very much.
Thank you.
And it's like